Welcome to the Prevea Health presentation all about concussions. Let's welcome Dr. Jeremy Metzler as your presenter for tonight.
Good evening, everyone. I hope everyone's having a great day and early evening. Today, we're going to talk about concussion prevention and management. Like I said, my name is Jeremy Metzler. I'm a sports medicine primary care physician, so I see full scope family medicine patients as well as non-operative sports medicine and concussions. I've been with Prevea since 2010. I'm the medical director of the Prevea Sports Medicine Program, also the team physician at UWGB and St. Albert College. I trained at undergrad at Madison, went to Michigan State for medical school, and then residency in Appleton, and went back to Michigan State for my fellowship. Like I said earlier, I pretty much do everything full scope family medicine, and then sports medicine and non-operative orthopedics. There's myself in the Green Bay area, as well as Dr. Romandine Kratz, and then Dr. Ulgens over at the Chippewa Valley, if anybody is on from there. So concussions have really been in the forefront since about 2001, which is when the first International Concussion Conference was held. They've had them pretty regularly, the last one being in 2016, and we'll kind of go over the recommendations that were based off of that conference. There is one scheduled for later this year in Amsterdam. And then we'll also go over some new recommendations that have come out between the two international conferences. I, for one, probably sustained multiple concussions during my high school football career, which was before 2001, which is really when things started to take off. So we'll kind of talk about the fifth international consensus statement at this time. So sports-related concussion is a traumatic brain injury induced by biomechanical forces. So it can either be a direct force to an object or something hitting the head. It's also important to know that it can occur if there's a blow to the other parts of the body that transmit the force to the head. Typically, symptoms occur rather rapidly and are short-lived and improve over time. However, there are some cases that the symptoms can take minutes to hours to show. We've had a couple of cases that's 48 to 72 hours after the original impact when they develop symptoms consistent with the concussion, which makes it very tricky to know whether or not these individuals are safe to return to activity when we see an incident on a playing field or surface. Typically, these are more of a functional disturbance in the brain and not a structural abnormality. Thus, standard imaging, CT scans, MRIs are not really needed and will typically not show any issues if it's truly a concussion. Also important to know that a loss of consciousness is not needed. And if there's a loss of consciousness, it doesn't necessarily determine the significance of a concussion. Concussions can occur everywhere. Again, most of the data is based off of athletic participation, but they can occur in motor vehicle accidents, work accidents, and just falls and other accidents that can occur anywhere. I would say the minority of my patients I see for concussions are athletes. Most of them are either accidents or motor vehicle accidents. So sports-related concussion, it's an involvent injury in the acute phase with rapidly changing clinical signs and symptoms. So it's very important to monitor these athletes or individuals for pretty closely after the injury, just to make sure things aren't rapidly declining, which would be one reason to present to the emergency department. The concussions are a very complex injury and very difficult to diagnose, assess, and manage. And as you'll see later on, the recommendations of treatment have changed pretty rapidly over time. And again, a majority of these occur without a loss of consciousness or neurological signs. At times on the playing field, we'll see posturing, which is where they bring their arms up like they're hugging themselves. That's typically, those are neurological signs and are concerning at times. So the recommendations currently, and again, this is more for non-professional athletes, is if they show any signs or symptoms of concussion, they should be evaluated by a physician and removed from removed from play immediately at that time. Again, the ABCs definitely we want to continue to monitor those, meaning airway, breathing, circulation, in case there is more of a significant injury to the musculoskeletal system, including the cervical spine. It's better to treat these early on and treat them rather quickly. In the past, we would keep them home and not let them do any activities, but those recommendations have changed a lot. And there's actually very good data that demonstrates that the sooner you seek care, the better you will be overall, and the quicker you'll recover. And then it's also anybody diagnosed with a sports-related concussion should not be allowed to return the day of the injury. So symptoms of concussions are kind of broken up into different clinical domains. There's somatic or headache, cognitive, emotional symptoms. There's physical signs, balance impairment, which we see quite often, behavioral changes. And this is where it's very important to have someone that knows these athletes very well to evaluate them, because we'll have athletes that are typically very shy or non-funny, and then they'll be very funny and interactive on the sidelines, which is a complete change in their behavior. A lot of times they'll have some cognitive impairments, slowed reaction times, difficulties remembering plays, those types of things. And then not so much early on, or not so much acutely, but we'll see a lot of sleep and wake disturbances in these individuals. So as far as getting back into physical activity after a concussion, there is a return to play protocol that we use, and it really just includes starting very slow activities, very low activities, and increasing slowly but surely at a stepwise progression. There's a lot of different variations of this, but pretty much everyone uses some sort of variation. And in addition to that, there's also a return to school strategy. So we know that a lot of these kids cognitively can't handle a full day of school. So we typically start them, doing home activities, school activities at home, and then gradually build up from there. And then a lot of times we'll head them or send them back to school, part days, half days, whatever they can tolerate, and kind of increase from there. We typically, I don't say typically, we always want them to be back to school full-time before they return to athletics or physical activity full-time without restrictions. So now we'll talk a little about differences between pediatric and adult concussions. So majority of concussions occur at 4 weeks post-impact or post-injury. However, nearly 30% will have symptoms lasting longer than 1 month, which is a pretty drastic timeline if you think about our kids. This impacts academic performance, involvement in extracurricular activities, and also a lower quality of life. When we're talking about prolonged symptoms, typically headache and fatigue are the most common symptom combination. Vision changes are the least reported symptom, but when they are present, they are the highest overall symptom burden. So they can be very, very severe when they are present. So years ago, we would not start physical activity until they're completely asymptomatic. Now the recommendations are to start it at least by the 72-hour mark. A lot of times, depending on our older athletes, we'll actually start them at 24 to 48 hours. Depending on how they're feeling at that time. When we do this, they actually have lower symptoms at the 2-week mark, and there's typically a quicker resolution of symptoms completely when starting physical activity early on. There is a lot of data and studies done at the University of Buffalo. They've looked at different things, including putting these individuals on a treadmill almost immediately after their injury, and then checking for symptoms, and they can actually pretty well indicate who have prolonged symptoms versus those who are going to get better based on their exercise tolerance early on. And this data continues to change and continues to be released. There's a lot of data I saw a couple of weeks ago at my conference that has not been released yet, but looks very encouraging for that early physical activity. Children's Hospital of Philadelphia looked at concussions between July 1st, 2012 and June 30th, 2014, so a 2-year span. They had almost 8,300 total concussions. 70% of those were sports related, and 40% were from contact or collision sports. as you can see, the younger kids, less than age 4, minimally of those were sports related. Most of those are going to be falls, accidents. And then as you get older and start to participate in more sports, of course, we're going to see more concussions from them. Again, the 30% of the non-sports related, third being from falls and third being from struck by an object. So male versus female, there's actually no difference in recovery time, which is something relatively new. This has not been something that's been thought of to occur over the years ago. We always thought males would improve faster than females, but the new data shows that it's actually a pretty similar comparison. There's always one thought that the males covered quicker because they were less honest about their symptoms, but who knows? Males had a longer recovery in limited contact sports versus collision sports compared to females, which is interesting. And then males had limited contact sports were the longest recovery, and then full or non-contact sports. Not quite sure what that means or why that is, but it's still stuff that we continue to look on from that, or look into from that standpoint. So this is physical intervention. So we know that sub-threshold aerobic exercise has affected decreasing symptoms and also leads to a quicker recovery time. It's nice to also get them to be exercising again, because most of these, especially athletes, are used to exercising. So if we can get them doing something physically, they start to feel better just overall as well. There is a bunch of different types of therapies out there that are available. Physical therapy for cervical, neck issues, those types of things. There's oculomotor and vestibular therapy, which are more specialized therapy. When they looked at studies using one of these versus the other, there was no benefit when they were used alone. However, when they are tailored to an individual, there's up to 50% decrease in the days to full recovery. As part of our concussion clinic here at Prevea, we do have vestibular and physical therapists that are part of our concussion team, who we tend to get our athletes or all individuals in pretty quickly with them, because we know that can be a huge improvement in their recovery. Sideline concussion evaluation can be very tricky. The symptom score is the best tool that we have, which is asking the athlete or the injured individual about symptoms related to 22 different symptoms that could be related to a concussion. There's some other tests out there looking at balance, looking at eye movement, but none of them have been shown to be reliable over periods of time and on repeat testing. So this is the Sports Concussion Assessment Tool. This was put out by the 5th International Conference of Concussions. It demonstrates a lot of different things, looking for cognitive, delayed recall, some orientation questions, memory, and then a lot of symptoms. It's nice when we have baselines of all of these for our athletes, which is very difficult to do at the middle school and high school levels. Even our college level athletes, it's sometimes hard to have baselines because this takes a while to go through all the testing. When they looked at non-sports related concussions in U.S. undergraduates, there was a higher incidence of concussions that were non-sports related versus sports related in college students. So now we're going to talk about the most recent updates in sports related concussions. This was put out by the American Medical Society of Sports Medicine as part of their team position statement in 2021. Again, it defined a sports-related concussion as a traumatic brain injury, a pathophysiological process affecting the brain induced by direct or indirect biomechanical forces such as a blow to the head or body. And this definition continues to change over time, depending on who's recommending it, etc. But again, it's pretty much all the same, where it's a traumatic brain injury that affects the process in the brain with forces. So common features of concussions, typically a rapid onset, as we discussed previously, of short-lived neurological impairment that typically resolves spontaneously. Acute signs and symptoms reflect a functional disturbance rather than a structural injury. And a range of clinical symptoms can range from loss of consciousness to not. Imaging studies not typically needed and attained are typically normal. And then there's other signs and symptoms that are not explained by medical issues that we want to make sure that sometimes there's co-founding factors that can play a role in symptoms as well. So there's multiple different concussions that can occur at different sports. We do see that rates are typically higher in competition than in practice. And that partly is because we decrease the amount of potential head contacts and exposures they receive in practice with laws and rules that have come down from football and rugby and soccer and those types of things. We still actually see a higher percentage of concussions that occur in practice based off a number of contact days, those types of things, but overall the raw number is higher in competition. We do see a higher report of sports-related concussions in female athletes compared to males as well. And there are multiple different theories on why that occurs, with nothing that's really been solidified as far as one reasoning for that. Typically higher rate of concussions in those with a prior history of concussion, those with a history of ADHD, depression, other things such as learning disabilities as well. Red flag symptoms, which is something that you should seek emergently medical care for. So if they have a seizure at the time of impact or shortly afterwards, if there's more than a brief loss of consciousness, so more than a few minutes, they definitely want to be evaluated in the emergency department at that time. If they have a worsening or severe headache that causes, persistent or recurrent emesis, that would be another reason to have them evaluated sooner than later. And then if their symptoms get worse as time progresses, which is one of the reasons we want to watch these individuals afterwards for a period of time. However, it does not mean, like was recommended years ago, to wake them up from sleep every few hours to check on them. It's really just monitoring them while they're awake and monitoring them while they're sleeping, but not waking them up, because we know that sleep early on is very important in the recovery of that brain. We also want to make sure that there's no evidence of more of a peripheral neurological abnormalities such as paresthesias, weakness into extremities. We want to reassess that cervical spine as well. So symptoms, as we briefly discussed, can be broken up into different categories. So cognitive, we talk about confusion, amnesia, loss of consciousness, disorientation. A lot of times we'll see they just have this vacant stare, their inability to focus, they can't really answer questions appropriately. And then there's affective concussions, which are more emotional and irritability, anxiety and sadness. Again, a lot of times those don't show up right away. That's something we'll see as the concussion progresses or as they continue through the process. Somatic are also very common. Headaches, dizziness, balance disruption, nausea, vomiting, visual disturbances. So most likely the symptoms we see at the onset of the head injury are somatic and cognitive, and then the affective and then sleep disturbance will come on later or as they progress through the healing process. So as we discussed slightly before, starting school later in the day, doing half days, going to certain classes. As we know, some teachers teach differently. Sometimes there's whiteboards, projectors, that all can affect how students are able to tolerate returning to class. We typically ask the teachers allow them to finish or more time to finish assignments and tests, non-timing tests, those types of things. We also ask that they're able to sit in a quiet room and do things on their own if they have symptoms in the large classroom, which can occur because there's so much things going on around them that can set off their senses. Typically, what happens with a head injury and concussion is that the frontal lobe is no longer able to weed out the useless information. So everything that comes in from any little noise that's occurring around them, the brain thinks is very important, and they just get easily overwhelmed. We ask about rest break, or we recommend rest breaks during the day, no more than one test or quiz per day, shorter assignments. Allow them to have repetition and memory cues. So sometimes it's them taking notes as well as a classmate taking note and reading it back to them later. Students helpers and tutors can be helpful as well. And then it's also, we just want reassurance from teachers that the child will be supported while getting better. Athletes should not go back to sports until they're back to learning without symptoms getting significantly worse and no longer need any changes or combinations as previously discussed. So again, if they're not able to tolerate a full day of school, there's no way I'm going to allow them to return to any significant sports activities. The number and severity of initial symptom burden is the best predictor for the duration of recovery. So if they have a lot of symptoms early on, or if they have a severe symptoms early on, they likely have a prolonged recovery. The recommendations now, instead of complete cognitive and physical rest, are limited cognitive rest and early sub-symptom threshold exercises is recommended. So we want these kids or adults or anybody from that standpoint to be in their normal environment as much as possible, be around their peers or friends, which can be supportive of them as well. The biggest risk factor for sustaining a concussion is sustaining a first concussion. And the more concussions you have, there's an increased risk of sustaining another concussion in the future as well. And then complete clinical recovery decreases the risk of subsequent concussions. So we know that if athletes return to activity prior to being completely symptom-free, there's a high chance that they sustain another concussion during that time. So persistent symptoms after concussions, currently defined as 2 weeks for adults, which, to be honest with you, we see a lot of concussions that have much longer recovery than 2 weeks, and then also 4 weeks for children. Again, it's a very complex injury. It's not thought to be caused by a single pathological process and likely involves multiple different things within the brain, which is why we see multiple different symptoms from that standpoint. The saying among us who see concussions is that when you've seen one concussion, you've seen one concussion, because typically there's never a concussion that is exactly the same as a previous concussion, even within an individual. And there's a lot of other factors that can play a role into the recovery, such as pre-existing conditions, coexisting and resulting biopsychosocial factors. Again, we want these kids or adults to be around their peers because that's a support group. So if we take them away from their peers, sometimes that can be somewhat, confusing to the patient as well. We talk about taking cell phones away from our, teenagers, and they freak out when they're not on social media, knowing what all their friends are doing. So if they're freaking out about that, is that allowing the brain to recover, or do we just allow them to be on their phones as long as their symptoms do not get worse? So risk factors for developing persisting symptoms, again, as discussed a little bit previously, high symptom load immediately after injury. If we do not, or if we do the prolonged strict cognitive and physical rest, that can lead to a prolonged recovery as well. So that's why we want to get them into doing some things cognitively and physically within that first typically 24 to 72 hours. And then if they are inadequately treated early on, or if the concussion was unrecognized, which sometimes occurs, especially in those situations where there's not an athletic trainer involved to monitor them. If they develop another direct or indirect blow to the head while symptomatic, can cause persistent symptoms as well. As slightly previously discussed, personal or family history of migraine disorder, mood disorders, those types of things can lead to higher risk of prolonged symptoms. Learning difficulties, family and social stressors, all risk factors as well. So typically, if there's anything psychological where the brain is already affected, adding another stress to that can lead to prolonged symptoms. Protection against persistent symptoms. One, and probably the best thing we do, is remove from play immediately after the injury. We know those individuals who continue to play immediately after injury have prolonged symptoms about twice as often as those who are removed immediately. And then instituting the physical and cognitive rest for those first 24 hours, and then starting to increase gradual return to both physical and cognitive activities that do not make their symptoms worse can be beneficial. So mainly symptoms we see, prolonged symptoms, are fatigue. So we try to focus on the suspected primary cause, which is typically poor sleep. Sleep is very important. That's typically when our brain recovers normally. And if we're not sleeping well after a head injury, our brain just doesn't have that time to recover. So we do use a lot of different techniques to help with sleep. We use a lot of meditation. We recommend different supplements such as melatonin, different medications such as Benadryl. We will use we will use prescription medications such as amitriptyline, as well as trazodone at times to help with sleep. Again, depression can lead to poor sleep and fatigue. We want to make sure they're eating normally as well to make sure they're getting the calorie intake they need to function. Mental health issues, so anxiety and mood, we would treat them as we normally do with counseling and medications. We send quite a few of our patients to counseling, especially those involved in accidents, motor vehicle accidents in particular, because a lot of them will develop some PTSD associated with that as well. And counseling can be very helpful in trying to treat those symptoms. We do use medications on occasion. The one downside of, as people know, depression, anxiety medication can take 4 to 6 weeks to build up in your system. So hopefully by that time, the symptoms have resolved. But we do use medications on occasion. And then headache and migraines, about 10 to 30% of people can have persistent headaches or migraines after a closed head injury with concussion. Again, that doesn't necessarily mean they can't return to physical activity or return to their sport, but something we may have to consider treating with different medications. We also want to evaluate for any pre-existing underlying disorders. Sometimes we'll see people develop a migraine symptoms afterwards, and they'd have a family history of migraine disorder. So were they going to develop a migraine disorder anyways? Did the head injury bring it on sooner, cause it to be more severe? And it's hard to know those answers. So people always ask if they develop headaches after a head injury or developed anxiety or depression, did the concussion cause this? And it's really difficult to know in many of these situations. The most important thing I educate my patients on is that we treat the symptoms no matter what the cause is. So if it was the concussion or not, doesn't really change how I'm going to recommend treating those symptoms. Again, sleep disturbance, we kind of talked about this, can be a lot of individuals will come in and say I'm sleeping all the time, but when they wake up, they don't feel rested. So it's not always the quantity of sleep, it's more the quality of sleep. That's very important. We talked about different medications already that we can use, sleep hygiene, including screen time in the bed, which is something we try to recommend against at all times. Vestibular and oculomotor dysfunction, so balance, eye tracking disorders can definitely be caused by concussions, but can also result in prolonged symptoms afterwards. Thus, we do use a lot of our vestibular therapists for evaluation. I would say probably 90% of the patients I see in the clinic end up in vestibular therapy for at least an initial evaluation. And then again, given that they're physical therapists, they can also help work on the neck as well. So prevention of concussions, primary prevention is not completely possible. Helmets do not prevent against sports-related concussions. Helmets were originally developed to protect against skull fractures, and they do a great job in doing that. There are certain concussion models or helmets that can possibly decrease the rate of concussions. And the NFL puts out a nice study every year of different helmets that they've tested based off of different things that they test for, what they recommend as far as which helmets are good, which ones should be avoided, etc. There is currently no evidence to support the use of headgear or helmets in sports to prevent concussions. Again, we see this a lot in soccer players wearing headgear or the headband that may or may not prevent concussions, and nothing, again, is 100% effective. There's also some theory that when we protect the head, that we're actually giving these athletes reason to put their head in different exposures, which could increase the rate of concussions. When college hockey went to mandatory full face masks 20 to 30 years ago, the number of facial injuries went way down, but the number of head and neck injuries went up because they would put themselves in situations to get a blow to the head that they wouldn't have otherwise when their faces were exposed. Improper use of the head gear, such as proper or improper hitting, tackling, those types of things can increase risk of concussion, which is one of the reasons that we're so focused on teaching proper tackling techniques and also making sure that if someone does do something improperly, that they are penalized for that during games. Mouth guards, that's always an interesting question. They have not been shown to decrease the prevalence of concussions, but they have not been shown not to decrease the prevalence. So again, mouth guards are typically recommended for decrease in the risk of dental and oral injuries, and they may in fact help with decreasing the risk of concussions as well. Other strategies to prevent concussions. Again, we see this a lot in limiting our contact drills in practice. So pretty much all tackling or collision sports have rules on how much time they can spend each week doing full contact practice, such as blocking, tackling, checking in hockey. So we really kind of limit those potential head exposures by decreasing that time in practice. We know that the proper fitting equipment can help decrease some as well. And then we kind of discussed a little bit briefly before enforcement of rules that prohibit hits to the head or potentially unsafe contact. Rule changes, so we'll see there's no checking in youth ice hockey. Kickoff returns have changed dramatically in professional and collegiate sports. Other than contact collision sports, limiting the height of the pyramid in cheerleading. I actually, during my fellowship year, had to spine board 2 cheerleaders who fell off of the pyramid. So it does happen quite often from that standpoint. There's also rules against heading a soccer ball in certain ages as well. And then we need to have more research into cervical spine strengthening, neuromuscular training as primary prevention strategies. That's one thought of why females experience more concussions than males in similar sports, is that their cervical spine strength may not be the same, thus unable to offset some of those forces that the body and the head are receiving. This is a list of references. Again, Dr. Kratz and myself are in the Green Bay area to help with anybody with closed head injury and concussions, and Dr. Olgan's out in Chippewa Valley / Wausau area or Eau Claire area to help with that as well. Any questions?
We would definitely like to thank you, Dr. Metzler, for the presentation, and thank all of you for attending tonight's presentation. Hopefully you found it helpful and valuable. Certainly, if you have any questions, we're happy to hang around here for a few more minutes. Otherwise, if you think of questions down the road, please feel free to contact us at Prevea Health, and we will definitely be happy to assist you further.